All right, we've got a few people joined now. We've got about 19, 20 people. Oh, wow, it's all coming on quickly. Just wait for a few more people to come on board. Thank you so much, Kunwar and Ravi, for being here today for us. We're so grateful to have you. And thank you, Chris, as well. I'm just going to wait for a few more people to click on board. They're coming along quickly. Hope everyone's got their tea. Ravi, have you got tea? Beautiful.
Ready to go?
Beautiful, yes. Got my tea here. Tea bag, very classy. Right, while we're waiting for people to come along, I'll just let you know that we've got a, thought we might have a bit of time, just a couple of minutes as people log on. I've got a little poll going for everyone who's brought their teas or coffees along, just to give us a little vote. Let us know what you've got. Oh, hello. Hi, Philly. Said hello. We have a Q&A section at the bottom if everyone wants to say hi and leave your questions. I'll give everyone about 2 more minutes and then I will start. Chris has got a wonderful tea cozy, which his wife has knitted, which we were all admiring before. It's got, was it licorice all sorts on the top of it? It's very cool. Proper tea in there too, which is very impressive. I've just got tea bag.
Don't use tea bags.
No, we've, my husband's uncle is very anti tea bags, but very easy for me. All right, we've still got quite a few more people to go. We were lucky enough, we've got over 100 people who have joined. Nikki's got a coffee. Beautiful. Someone's just emailing for the link. Hopefully everybody should be coming in.
Somebody has asked a question, Jenny, maybe I can take the question. How long can you live after a quadruple bypass?
Oh, yes, absolutely. Thank you.
It's not a COVID question. Look, if you've had it done in a timely way, there's no reason why you can't have normal life expectancy in this era, for whoever asked that question.
Yeah. Thank you, Ravi. That's handy. We're getting all sorts of information now. All right. All right, what do you think, Chris? Should we get started?
Yes, I think let's get cranked up.
Okay.
Absolutely.
All right. Well, I'll just thank you so much, everyone, for coming along and joining us for tea today. We're so grateful for you to be here for our very first Tea with the Experts webinar. We're planning on running these every quarter for our Heart Health Club members. So thank you so much, Ravi and Kunwar, for being the first ones to come on board. I've got my English breakfast tea, and I hope that everyone's got their tea or coffee or whatever you chose to bring along today. Some of you may know me from the emails that I send out, but to put a face to a name, my name is Jenny and I am the Communications Manager at Heart Research Australia. Just to let you all know, there's going to be over 100 of you joining us today. So I do have your cameras and your microphones switched off, and we will be recording this. So if you have any questions, there is a Q&A section at the bottom where you can type in any questions you've got, and we'll get to them at the end of the session. We'll get to as many as we can. And there's also a little chat section if you want to, so Stephen's just written back to you, Ravi. Thank you very much, Stephen, for that. So there's a chat section if you want to just add a little note. So thank you so much, everyone. I just want to introduce you. So in the top corner with the jacket on, we've got Chris Russell. Chris is one of our wonderful ambassadors who has so kindly volunteered today to chat with our researchers and to get to the bottom of those questions. It's at the top of all of our minds at the moment, living through this COVID-19 pandemic. It's completely changed all of our lives, and I know I've got a million questions that's been going through my head with it. So thank you so much, Chris, for coming along. So I'll hand over to you now.
Okay, thanks, Jenny. And I think this will be an interesting day. For those of you who I haven't met, I should explain, I am definitely not a medico. I'm just a humble agricultural scientist. So, but I did have a heart attack back in 2004. And I've been working with North Shore Heart Research ever since. Why don't I just turn that off so that we don't get, sorry about that. Ever since on just making sure that we can make use of all the information that comes out of that fantastic organisation at Royal North Shore Hospital. So what we're going to be doing today is working our way through some of the key questions you all have in your mind about the links between COVID-19 and between people who suffer from heart disease or who may suffer from heart disease. And we're very lucky to have two of the finest researchers and cardiologists in Australia with us this morning. So you're hearing it straight from the horse's mouth. So if I could kick straight off, maybe with you, Ravi or Kunwar, why do half the people who catch COVID-19 die?
Yeah, so Chris, very important question. And just in the way of introduction, I'm the head of cardiology in the North Shore campus, and Kunwar is our senior registrar. And we've undertaken this study, which we'll discuss today, to address some of the to address that specific question about the link between COVID and heart disease. I think all of you in the audience will probably remember when COVID-19 initially started in China. We thought we may be exempt from this disease, and then suddenly when it hit Italy, we all became quite frightened. And the information that came from Italy was very interesting. The healthcare system flooded very rapidly, so that patients that acquired this disease ended up getting very sick and presenting to emergency departments in droves, to the point where morgues filled up, and there were just the healthcare system was genuinely overwhelmed. And this happened not in poor parts of Italy, but in the affluent parts of Italy. And so I've got friends, from my time in Oxford, I've got friends that now head up departments in Italy. And when I chatted to them, it became very clear that the healthcare workers and the administrators had to make practical and pragmatic decisions about who they could treat, because the corridors of emergency were filled with patients, as you've all seen on TV, with patients that needed treatment. And so they made pragmatic decisions. They made age cutoffs where certain age groups would be treated and certain age groups wouldn't be treated. And so from that preliminary data from China and Italy, it appeared that patients with heart disease and elderly patients might be more likely to die of COVID-19 if they were admitted to hospital. So that was the observation. But that data, just based on what I've said, is interesting, because if you don't treat people who are over the age of 65, which was happening in some parts of Italy, then obviously you then miss treating people that could potentially benefit. And as you know, heart disease, whilst you can be young and have heart disease, it's largely a disease that increases with age. And so to try and untease the question as to whether this is just because we weren't treating these patients or whether heart disease in itself was leading to people dying was something that we didn't know. The second thing, and I guess for those of you who are taking medications like ACE inhibitors or angiotensin receptor blockers for high blood pressure or heart failure or after a heart attack, the ACE receptor, which is where the ACE inhibitor lands, is
an ACE inhibitor is like metoprolol, isn't it, or something?
It's things that end in pril, so enalapril, ramipril, captopril.
Ramipril, okay, correct. Great, yep.
So the olols are the beta blockers, and the ACE inhibitors are, and this is something that a lot of you in the audience would be very familiar with. And viruses can't replicate without using your own cellular machinery. So they have to get into your cells to replicate. And the way they dock onto your cells is via this ACE receptor. So without getting into too much detail, there became a biological link that perhaps these viruses, because they had to bind to this ACE2 receptor, that this ACE2 receptor might be implicated, because we know that the ACE2 receptor is increased in those patients with cardiac disease. So first, there was the observation there were numerically more people with heart disease that were dying of COVID-19. And second, there was a sort of explanation as to why there could be a link between COVID-19 and the heart. I'll let Kunwar expand on that a bit further, Kunwar, in terms of the specific implications for heart patients.
Before we get to that, could I ask the question, is there any difference between young people with heart disease, say congenital heart disease, and old people, who are over 70 who've got heart disease in terms of their the likelihood of them getting very sick?
Look, we don't know that, and that's what the purpose of our study is to identify whether this is actually a function of age, or is it a function of actually having cardiac disease that predicts the likelihood of you getting adversely affected by COVID-19.
And do we think that the COVID-19 affects the heart muscle itself, and that's what the problem is, or does it affect the beating?
So COVID-19 can affect lots of things. One of firstly, it causes a pneumonia, and then secondly, it causes probably about 10 days after the original infection, it causes an overwhelming inflammatory response, and that activates clotting, it activates rhythm disturbances, so you get electrical abnormalities, you get clotting abnormalities, and it can affect the heart muscle as well.
Right. So Kunwar, just tell us how the severity of COVID-19 is affected by things like heart failure versus blood pressure versus clotted arteries versus all the other things, bad valves and so on.
Yeah, so that's a very important question, and that's one of the questions that Ravi and I are studying. But basically, patients who have pre-existing cardiovascular disease, all of those diseases that you talk about, if they do get COVID, they're much more likely to have to be hospitalized and to have a more severe form of COVID. They're much more likely to end up in ICU, and they're much more likely to die from COVID infection. So that's why the big message that we've been putting out to the community, and especially with patients with pre-existing cardiovascular disease, things like high blood pressure, high cholesterol, valve disease, we want those patients to do everything they can to avoid catching COVID, because if they get COVID, the chances that they'll end up in hospital is significantly higher than patients without those comorbidities.
So it doesn't matter which one of those things, there's none of them are more of a problem than others. They're all issues that are going to make you sicker.
Look, we don't know for sure at the moment, because all of the studies that have mainly come out, they've been lumping patients together as pre-existing cardiovascular disease by and large. And like Ravi talked about, there are still some limitations with a lot of those studies where they don't correct for age of patients. So it's hard to really get the true answer at the moment, and hopefully our study will do that. But the main thing is, if in patients who have pre-existing cardiovascular disease, if they do end up getting it, they end up being much sicker. And so the question is, why? Why is it that patients with pre-existing heart problems end up much sicker if they catch COVID? I mean, there is this theory that these patients just have less reserve. So with all of the things that Ravi mentioned, the increased clotting that's happening, the increased pressures that are building up within the lungs, amongst other things, the increased stress on the heart, to the muscle and to the rhythms, it raises a question that maybe these patients who already have, heart disease just have a lower reserve, and therefore they don't tolerate COVID as well. But we don't know that for sure yet. So there's a lot of unknowns still, despite COVID's a fascinating disease in the sense that so many people around the world have it, right? The numbers are mind-boggling, yet there's still so much we don't know about it and why it affects.
But Chris, the important question you ask is there any specific subgroup of heart patients, whether you've had a heart attack or you have atrial fibrillation or you've got heart failure, are any of those groups more likely to die or be badly affected by COVID-19? The answer is we don't know. What I tell my patients who've had a significant cardiac history is to be particularly vigilant at this point in time, because that's what the data suggests. So trying to ensure that you implement measures to reduce the chance of you getting COVID-19.
So does the COVID-19 make the heart disease worse and you die from that, or does the heart disease make the COVID worse and you die from that?
I think, as Kunwar says, I think that the concept is it's probably to do with the reserve. It's to do with your underlying physical reserve or resilience to tolerate this infection and the subsequent inflammation, which is overwhelming. And I think that's where we think the key lies. Whether the severity of the disease is affected in patients with COVID-19 remains unclear. So because of that link I talked about, this ACE2 receptors increased in people with heart disease. So if you've got more areas for this virus to attach, will that make you more likely to be overwhelmed by the virus? That also remains unclear. But certainly,
can the COVID cause heart disease?
Yes, so COVID-19 can cause inflammation of the heart. It can cause a failure of the heart. It can also cause heart attacks because it causes clotting, overwhelming clotting. And so certainly there have been some peculiar patterns of heart attacks seen in patients with COVID-19 around the world.
So if you don't have any heart disease, is it conceivable that you can catch COVID and that can give you heart disease, particularly, you know, arrhythmias and valve disease? I guess clotting is you get that because of the COVID, but those other things you're talking about, you know, can it actually bring them on when you've never had it before?
Yeah, look, that's a good question. So any virus, I think just to be generic, any virus or any infection or inflammation that affects the body. So if any of you have had pneumonia and you come into hospital, the chance of you getting an arrhythmia or electrical disturbance is not inconsequential. It's just that your body is overwhelmed, and in response to that stress, you can get arrhythmias or electrical instability, atrial fibrillation or AF, as some of you may or may not be aware of. So that is seen in COVID-19. And having direct damage to the heart is also seen, and that's probably caused by clotting or the virus directly embedding itself in the muscle and causing the muscle to fail. Now that is also seen with other viruses. This isn't specific to COVID-19, but we are seeing, because of the pandemic and how many people are affected, the denominator is so big that we are seeing a larger numerator, is probably the observation or the comment to make.
So, Kunwar, if I can come back to Ravi throwing to you a little while ago about medications. Remember, I'm just a simple agger, so, you know, long words I'm not good at. But my understanding is initially the feeling was that because this virus sort of sticks its sticker into a cell and actually binds up some of the enzymes of the same enzymes that heart drugs are also trying to enhance or limit, that there was some kind of antagonistic reaction there between them. Is that a fair summary of what they were worried about?
Yeah, I think that's a very good summary of what they were worried about. And those drugs that you talk about, they're mainly blood pressure drugs, so the ACE inhibitors and the ARBs. And there was initially quite a reasonable amount of concern that people didn't know what would be the outcome for patients who are on these medications if they catch COVID. Since then, there's been a lot of work that's been put in to try and answer this question because there's so many patients on these medications, and there'll be many of the attendees today that are on them. And the long story short, it seems like from all the data that we have is that there's no harmful effect from being on these medications. In fact, there may even be a beneficial effect for those that do end up catching COVID. So being on these medications from the data that we have at current is not harmful. So patients should continue to take these medications. And I think we have a question to that effect on the question and answer from Ian, who asked a question about Olmatex. So that's one of those angiotensin receptor blockers, those ARB medications. And so what we tell our patients is that they should continue on those medications. And even if they catch COVID, they should continue on those medications unless there's a specific reason to stop them. So there was a lot of concern about this early on, but I think now that the big international cardiac societies have gone together and made some strong words on it, saying that patients should continue because at the very least, there's no trend to show that patients are worse off. If anything, patients may be better off.
Yeah, and I think Graham's also asked the same question, and I think certainly when we wrote the position paper for a cardiac society in the Medical Journal of Australia, I think this is around February or March, all international societies recommend that if you are on an ACE inhibitor or PRIL medication, that you continue it and you don't stop it, because and there is some data to suggest that it may even be protective. So I think if you're on it, don't stop it. There were some of my patients that did seriously think about stopping it because there was some media conjecture about that at the time.
So the other part of Ian's question was, is there any link between people with high cholesterol being also having a worse prognosis than others, regardless of whether they're heart attacks or not? Is there any link between cholesterol levels and the effects of COVID-19?
Yeah, I don't have a definitive answer on that. In most of the previous studies that I've looked at, certainly the patients with hypercholesterolemia have been grouped in with the patients with pre-existing cardiovascular disease. Looking at a subgroup analysis just purely of those with high cholesterol, I don't know, maybe Ravi, you know, but I'm not familiar with it.
Look, Chris, I think you're probably alluding to the fact that the ACC, American College of Cardiology, had some concerns about statin drugs and linkages and with COVID-19, but I think generally speaking, the risk benefit is that you maintain your drugs that you're taking and you don't stop it, because there's no drug that increases or decreases your susceptibility to COVID-19 or its severity.
So, okay, so coming back then to heart patients who catch COVID-19, let's say they're in the lucky 50% that survive it and they fully recover, does the experience make them then more susceptible to is their morbidity or their chance of being very sick from heart disease higher after that, or does it go back to the same as it was before they had the COVID-19?
Look, I think in the majority of people, if you got COVID-19, you would probably, and I'm just making an assumption that the majority of people would survive COVID-19, in that I don't think there would be any long-lasting effects, is my gut feeling. Although there is a small cohort that will be left with some level of damage to their heart muscle, for example, either from a heart attack or inflammation of the heart muscle. We haven't seen enough long-term data from places like the US, Italy, or China to see whether these effects on patients with underlying heart disease. So if you've had a heart attack and you've had some heart damage, you then get COVID, you get more damage. Is that damage caused by the virus sustained, or is that going to reverse? We just don't know, because the disease has only been around for 8 or 9 months. And so I think that's a good question. And I think, unfortunately, the time is the only thing that will reveal that answer as to whether COVID-19 will leave some scar that will cause mischief in the future. We don't know.
And I guess the other question, you mightn't know this either, but if people have had their heart attack resolved by bypass surgery, where they actually have, elastic alternative arteries grafted in, versus stented, where they've actually put a fixed piece of metal hose pipe inside their arteries, to be blunt, is there any difference in whether the COVID-19 is going to be worse for either one of those solutions, or no difference?
Kunwar, do you want to take this?
Look, again, I don't have an answer for that. As far as I'm aware, that hasn't been looked at specifically, whether patients who've had bypass surgery versus stenting done, there's any prognostic differences with COVID. So I think that's certainly a very interesting question, but I'm just not sure if there's any data on there, none that I've come across.
Yeah, so Chris, I think that unfortunately with a lot of these things, we haven't had the ability to separate those who've had bypass versus those that don't. I think the thing for the audience to appreciate is the majority of patients will actually get COVID-19 and get through it without a problem. I think that we know. But we do worry about those patients that get admitted to hospital. And then within that cohort, to work out those that got stents and those that ended up having bypass to see a difference is actually quite hard. And hopefully our study will give some insights into whether there is a signal in that specific area.
So that brings me to the study, the HROz COVID study, and it sounds like just this morning we probably created enough work for about the next 10 studies, but what are the key hypotheses that you actually want to test in this HROz COVID study, and how much is it going to cost to get all this done?
So the primary hypothesis, or the primary question that we have as part of HROz COVID is what is the prevalence of cardiovascular complications from COVID? So in patients who get COVID, end up in hospital, what proportion of those patients end up having some heart complication, whether that be abnormal heart rhythm, such as atrial fibrillation, or torsades, which we heard a lot about in the media, whether it be heart muscle damage, whether it be what we call cardiomyopathy or heart failure, whether it be a heart attack itself. We just don't know. So the worrying thing, and I think Ravi mentioned this at the beginning, was when COVID initially hit, when hospitals were overflowing in other parts of the world, there were all these reports coming out of patients having heart attacks, a significant number of proportion of patients having heart failure from COVID, or having scarring of the heart. But we just didn't know what proportion were having it. So there were all these case reports coming out, here are 10 patients who had this heart problem, here are 20 patients who had this heart problem. But that was always a numerator, and we never quite knew what the denominator was. So we didn't know out of how many tens of thousands we were finding these cases. So the question was, is it really common or is it uncommon, but we just have so many people? And so we still don't know the answer to this question, which is why, as part of the HROz COVID study, what we're doing is we're collecting data from every single patient that gets admitted to hospital, and looking at those patients and seeing how many of them go on during their hospitalization to get a heart problem, whether that be an abnormal rhythm or heart failure or anything like that. So that's one of the things that we're looking at. And the second thing we're looking at is what we were discussing before. You know, in all of these heart subgroups, which ones are the ones that patients are going to be most susceptible to death from COVID, essentially, or going to ICU or ending up intubated? So there's specific subgroups within those heart patients that we need to be more cautious with, or we need to tailor therapy more carefully. And then the other thing that we will be definitely looking at is what are the risk factors when patients present themselves to hospital that can kind of predict their outcomes. So heart patients who end up in your emergency department, how can you predict the trajectory of this patient as they go along? Is this someone who's safe to, you know, potentially go home, unlikely to have many complications, or is this someone who may have a lot of complications? And then finally, we're going to look at all of the medications and how they interact with patients' prognosis, their journey. So the patients who are on all of these different types of heart medications, how does that affect their journey throughout the hospital? They're the main things that we're looking at in the study.
So Ravi, you know, it's one of the interesting things in this being so urgent and so critical is everyone's become an instant expert. Even the President of the United States is an expert. So there've been all sorts of potential cures that have been mentioned, you know, out and some with catastrophic results. Are any of these sort of backyard cures, I'd almost call them, although some of them are recognised medications, being investigated in this? Are there any in here that have got legs potentially that we just don't understand enough about?
Great question. And I think the problem with when you have a new virus or a new disease, people scramble and try to repurpose old drugs. And certainly there's been one drug in particular that has shown promise, very expensive drug. It reduces the length of the duration of the disease a little. But in terms of curing COVID-19, I think none of us really think that there's going to be anything specific that will cure someone of COVID-19 if they get it. I think at the moment there's no therapy that I'm aware of, or Kunwar may know something different, that we think is going to cure COVID-19. I think all our bets are going to be on a vaccine to prevent getting COVID-19. The interesting question you do raise is that if you do get admitted to, say, our hospital or to any hospital, a lot of these drugs that are advocated by various experts may be utilized because some of them do have some benefit, but you can administer them in a controlled way. And sometimes you get a response. And I think this is the interesting part of the journey we're taking. For heart patients, some of these drugs, such as the drug hydroxychloroquine that was advocated by President Trump, can have adverse effects on the electrical system of the heart. And so, yes, it could be useful. The trials have shown that it doesn't really work. Some trials say it might have some benefits, but administering it in hospital when there's nothing else that we can give under controlled observation is reasonably safe. Drugs that were used for Ebola, for HIV have all been trialed, and all of these have a side effect profile that affects the heart. So it's important when we use these medications, particularly in heart patients, that we need to consider that in the therapy itself.
So in your study, are you hoping to come up with some not cures so much, but some treatments specifically to stop the effects on the heart? Whereas others are looking at how to actually stop COVID-19 in the first place. I accept that's a separate study, really. But in your case, with HROz COVID, are you hoping you'll come up with something and say, well, if you do catch it, providing we follow this course of action, we're likely to not see this increased mortality from people who have got heart disease?
Look, our study is an observational study, and what we may find is that, for example, as Kunwar, and I think as you asked the question earlier, is if you are on certain drugs for heart disease, ramipril or captopril, maybe you are more protected. Maybe you are less likely to have a severe form. Maybe you are less likely to be in ICU requiring ventilatory support. I don't think we'll come up with any medication that will cure or favorably influence COVID-19 beyond that. So I think we may also find that certain drugs may be associated with worse outcomes. So for example, if you're taking anti-inflammatory medications, we might find that exacerbates COVID-19 effects. So I think that's the sort of level of findings that we expect to be able to drill down on with numbers.
And when do you think we'll get some results that we can use out of this trial?
I'll let Kunwar take that. He's been working hard at analysing it. He's the brains behind it all.
So I think that should be pretty soon. I would imagine roughly within the next 8 weeks or so, we will get to some pretty big numbers. We've already got over 400 hospitalised patients from 18 different hospitals in Australia who have all contributed their data. We're getting new hospitals, especially out of Victoria, quite regularly. So those numbers are rising really fast as all of those patients who've been admitted to the Victorian hospitals come through. And there's a little bit of a lag between when they get admitted to when they end up in the database. Our target with the study is roughly 800 patients. So we expect we'll get there pretty soon. And hopefully you'll be able to read the publication very soon, and we'll be sure to share that with Heart Research Australia when it comes out.
So Jenny, could I throw back to you, in terms of the allocation of money from Heart Research Australia towards this research, has that meant you have to divert money from other causes? I mean, where are we at in terms of raising money for this Oz COVID study?
We're actually, I think a lot of the funds are coming in through Royal North Shore Hospital. Is that right, Ravi, for this?
We've had a number of we've had two donors. We've had Ramsay that have given us a large amount of money, and the North Shore LHD local health district has given us money, and the money's been given to Heart Research Australia to help with the study.
Yeah, which has been wonderful. And, we're just so fortunate because, Ravi's on our board. So it's been so great that we've been able to get him along and Kunwar along today to be able to share all the findings, because we knew it would be really interesting for all our donors and our supporters. So,
but just from an interesting point of view, if I could, Chris, just comment, is that running a trial like this, and credit to Kunwar, he's an advanced trainee at North Shore, so he has a busy clinical role. With a disease like COVID-19, when it started in New South Wales with the RIDE cluster, things were happening pretty quickly. And to get this trial up and running, required a lot of speed, a lot of effort, a lot of discussions with the ethics committee, getting protocols written in rapid time, because no one knew how quickly this disease would overwhelm the system. And we wanted to be in a position to try and capture this really quickly. I mean, even things like getting consent. How do we get a consent from a patient who is infectious? It would potentially infect the healthcare worker. There were lots and lots of questions to be asked, and so we have a good network around Australia. So we've got a number of hospitals on board, and they're all very keen and to contribute to this. So from organising a research study, this has been done probably faster than anything else I've ever run, and credit to Kunwar, and I think we've got a wonderful group of collaborators who've been really committed to trying to help us address the question.
Well, I must say, I think the whole world is grateful to our healthcare workers. You guys do an unbelievable job, and you've put yourself right at the front line. My own son is in the intensive care unit at Westmead, and I say from our own family experience, I just know how committed and dedicated and selfless you all are in almost not ignoring your risk, but, working within the risk to make sure you can try and bring health to us. And anything we can do by sticking a few bob in or helping you, we absolutely have the need to be able to do that. Jenny, have we got any time for a few questions now?
Yeah, we've got a few questions. I've just pulled out a couple. John has asked, I have read the virus can affect the myocardium itself amongst other organs. Is that so? And would it predispose to ongoing heart disease?
Yes, I think that's an excellent question, and the answer is yes, it can. We don't know what the frequency.
Just tell us what a myocardium is first.
Yeah, that's good. Okay, fair point. So the heart is a muscle. It's a pump. It pumps blood around the body, and the myocardium refers to the heart muscle. When you have a heart attack, the myocardium can die, or bits of the myocardium can die. When you have inflammation of the heart muscle, which is called myocarditis, that's what the virus does. It inflames the muscle, and that can cause the muscle to necrose or die. And so, yes, there have been a case series of the virus affecting the myocardium directly. And again, we don't know whether this is a long-term effect or not, and we don't know how frequently this occurs. We know that the heart is inflamed acutely in a significant proportion of patients who present to hospital. That's by measuring the troponin. For those of you in the on the online might be familiar with troponin level, which is a marker of injury to the heart muscle. We see that quite frequently in patients with COVID-19. So yes, there's a blip in the COVID-19, but does that translate, or does that mean that the heart is badly damaged? We don't know, and that's what we hope to try and find out.
Yeah, there's another question here which may or may not be related about allergies. You know, do children who have severe allergies, does that make them also, because heart disease is often an inflammation as well, does that mean they're more likely to be vulnerable to heart disease and or COVID-19 effects, or is there no relation known between allergies and these things at this point?
Kunwar, do you want to?
I haven't read anything about that relationship, but to be honest, I haven't looked into specifically patients who have atopic disease or allergic diseases and their reaction to COVID. So I haven't heard anything along those lines.
So the only, just as a tangent to the question, there is a disease called Kawasaki's disease, which is an autoimmune or immune type disease that affects the heart, that's been well described both in the UK and the US in kids that are affected with COVID-19. Whether there's any vulnerability or susceptibility to those with allergy, I don't think we know that yet.
Okay, any more questions in there, Jenny?
I've got another question from Graham. He said earlier you spoke about ACE inhibitors that end in PRIL. Am I understanding correctly that ACE inhibitors act to increase our protection?
That's what the data suggests. We don't know for sure, but it certainly doesn't cause any harm as was initially speculated. And if anything, it causes a benefit.
Right. And there's another one from someone who's anonymous that said, I have an aortic valve replacement. Does this still put me in the same group as having valve disease or heart failure?
So the answer to that, I would say, is we don't know, but probably we would treat anyone who's had a cardiac event as having heart disease. Now, obviously, if you've had a valve replacement and the valve is functioning normally, my assumption would be that you'd be more resilient to the effects of COVID-19 if you were to get it. But we don't know whether, just by virtue of the fact that you've had this valve problem, whether you're more susceptible or not. So we don't know that, but having a valve that's been replaced means your heart's pumping normally. So that's probably a good thing.
Yeah.
And our study should be able to dissect out that question, that if you've had a valve replacement, your valve's now working well, how are you going to go when you get COVID-19?
Yeah.
So Kunwar, can I ask you about the vaccines that are being worked on here and the speed with which this is being done? I mean, typically vaccines take years to go through all their safety trials, but of course the pressure is on to get something out by, next week, by the United States elections, by the Queensland elections, who knows? I'm just wondering whether there is a risk that we miss something that might affect our hearts while we're curing. I was reading, being in agriculture, of course, I was reading the other day about they found an element in, I think it's alpacas, llamas, camels, and sharks' blood that has a thing called a nanobody that wraps around the spikes on the outside of the coronavirus so it can't stick itself in and infect the cells. Sounded fascinating to me, but immediately you hear something like that, I mean, does it wrap around something else and block your heart? And, there are lots of questions here. I'm wondering whether we might miss those.
Yeah, look, I think that's a very interesting question. Obviously, with any treatment that's made available, it always has to go through trials. And part of those trials is to assess the safety of the medication, whatever medication that be, a heart medication or a vaccine. And I think we have to have our faith in the regulatory bodies within Australia and across the world, that before any vaccine is distributed, that the safety profile will be assessed. And that's what's actively being done right now. So with the Oxford vaccine and with the Moderna vaccine and all the different vaccines that are around, they're all undergoing trials to assess not only the efficacy, so does the vaccine work, but also the safety. I think we can't really say anything until we see the data behind it. But as Ravi said, really the end of the line here really is the vaccine. Until we get the vaccine, it's going to be a very tough road ahead for us for a very long time. But that's why there's so much pressure, I guess, to have the vaccine. But it's reassuring to see that even with the delay in recruitment recently with the Oxford trial, that safety is taking such a precedence here, and it should continue to do so. And I have no reason to expect why it wouldn't. So I think if a vaccine becomes available in a timely way, that's fantastic. But I think there will be there is a lot of work that's been done already to ensure that the vaccine that does eventually get distributed, or vaccines, will be safe. And I would put all my trust in the regulatory bodies, here in Australia and across the world, to ensure that's the case.
It's a strange dilemma, Chris. It's on one hand, we understand that our lives are completely different now with COVID-19. We can't travel, we can't do anything. And so people want a vaccine as quickly as possible. And the only way you can get it done as quickly as possible is to take shortcuts. And so I think the reason why people are expecting this to be sometime next year is because of that very reason, that we've got to try and ensure that the risk of something nasty emerging is reduced. And so I think that's probably the reason why we'll see this delay, because we need to make sure that we're not going to cause more harm. These vaccines can cause all sorts of funny reactions or induce other disease processes. So I think I'm pretty confident. I mean, the trial in Oxford, which is what we've subscribed to, shut down. I'm not sure for those of you in the audience, shut down a couple of weeks ago because a patient had died. And so they did a thorough investigation to work out whether it was linked to the vaccine trial, and the answer was no. So that trial has resumed. So the processes are pretty good to try and ensure that there's safety in as good as we can in terms of safety.
Great. Thank you, Ravi. So I think we probably have time just for one more question. We have a question from Martin. I'm not sure if this will be along the same vein as the aortic valve replacement question, but as a recent heart transplantee, would I be considered to have heart disease in the context of the present discussion?
Yes.
Yeah.
So the other associated question with that, Ravi or Kunwar, is, if you're on immunosuppressants because you've had a heart transplant, although you've got a new heart, which doesn't have any disease in it, hopefully, you're still on those suppressants. What's the effect of that on your susceptibility?
Yeah, so that's an excellent question. We do know that one of the immunosuppressants, so a number of immunosuppressants have been trialed in randomized controlled trials. And we do know from some of the work that's done out of the UK that there is a lot of promise. In fact, there is a mortality benefit from hospitalized patients who have an oxygen requirement of receiving steroids. It's one specific steroid tested, but other steroids being tested as well. So a steroid is an immunosuppressive drug. So in patients who end up in hospital, who end up on supplemental oxygen, we know that there is a benefit of steroid therapy. But whether that applies to patients who are already on steroids, that's a very difficult question. And I certainly don't know the answer to that, but that will be something very interesting to look at. We do know in general that patients who are immunosuppressed, so suppression of the immune system, typically when they get infections, that they're more susceptible to infections by virtue of suppression of the immune system. But COVID-19 is an interesting disease that there's hyperimmune response as well as part of it. And so there is a role in COVID potentially for immunomodulators. Yeah. Patients who are already on it, it's very difficult to say. I think certainly if you're a heart transplant, if you've received a heart transplant, you certainly should consider yourself in that.
Yeah. So Chris, just to summarize that, also the interesting observation just for the audience is that first, this virus affects your organ, it causes a pneumonia. You can die of the pneumonia. But once you sort of start recovering from the pneumonia after you've got it, but then at day 10, so I think Boris Johnson, for those of you who remember what happened to Boris, he was getting better from his infection, and then suddenly he went to ICU and then almost died. And that's that day 10 phase where the virus is sort of gone, but then the body suddenly mounts this overwhelming inflammation response, and that's the thing that knocks people off. Now, whether the immune suppression affects that is unclear. So I think at the moment we don't know the answer to whether being immunosuppressed makes things worse. We're probably more susceptible to infections in general. I think that would be fair to say. But if you get it, then is there a role for immunosuppression during the admission? And as Kunwar says, at least one immunosuppressant or steroid has shown benefit of some form.
All right, well, look, thank you. That's been a fantastic, I've certainly learned a heck of a lot. I'm sure everyone who's watching has as well. If I could just put in a little comment at the end, as in my role as an ambassador, you know, one of the things that really frustrates me about the system is how much time brainiacs like Ravi and Kunwar have to put into filling out forms to get money to do this stuff that we all think they should do. So I'd ask all of you who are watching today, if you've got some ability, you've got some resource to be able to support this through Heart Research Australia, whether it be by direct donations or as I've done by actually changing your wills and bequesting some of the money after you've gone to go to this work and save them having to spend all that time trying to chase money the entire time, I'd encourage you in the strongest way to try and do that. I'm a personal beneficiary of the work that went in years ago, and that's what saved my life back in 2004. So I'm obviously passionate about it, but thank you very much, Ravi. Thank you, Kunwar. I think that's been a fascinating debate. We wish you well in this study, and I hope that everyone will get behind you and give you whatever resources you need to bring it to the outcomes that we're all looking for. Thanks, Jenny. I'll pass back to you.
Yeah, absolutely. Thank you so much, Chris. And yes, thank you so much, Ravi and Kunwar, for coming along today and sharing those findings that you have. You know, we're so grateful for you taking your time. I know how busy you are and with all the work that you're doing. So thank you very much. And to all the attendees, thank you so much for coming along. And Chris, thank you so much yet again. You do such an amazing job helping to pull out all these great questions that we all have with our researchers when you do these speeches. So thank you so much. We're very, very grateful. And I will be recording this, so if anybody is interested in watching, going through and watching it again or passing it on to somebody else, just shoot through an email to me, just jenny@heartresearch.com.au, and I'll be including a link in for the people who signed up anyway. So thank you so much, everyone, for your time, and we'll hope to do this again in the next quarter. So thank you so much, guys. Bye.
Thank you.
Bye.